Thank you for joining for another interesting scenario in our urology exam preparation. Thank you for the trainee who has agreed to record the session so that it will be a good revision tool. You got a 55-year-old lady presented with history of generalized weight loss and lack of appetite. She's quite fit otherwise, no medical comorbidities. And when the GP arranged an ultrasound, it showed multiple echogenic shadows in the left kidney with possible post acoustic shadowing with evidence of possible stone. So the patient was referred to you as an outpatient. What will you do?
Okay, so I would see this patient in a general urology clinic. Begin by taking a history from the patient. So you say she's presented with weight loss. I'd like to know over what kind of time period this has happened, whether she's noticed any other systemic symptoms during this time and any organ-specific symptoms on systemic inquiry. And ask specifically about her kidneys, whether she's had any pain, loin pain, hematuria, bladder pain, any other red flag symptoms, whether she's got a history of urinary tract infection, urinary tract stones, any treatment for stones, and any family history for urinary tract stones. I'd also like to know her general medical background. Does she take any regular medications? Has she had any previous urological or gynecological procedures? And is she currently taking any hormone replacement therapy? And I'd like to know her social circumstances. Does she smoke? Does she consume alcohol? And then I would go on to undertake a chaperoned clinical examination with verbal consent, beginning by checking the patient's weight and comparing that with a previous value to determine and quantify the weight loss over this time period. Check the patient's BMI, check their general health status on examination, and then examine their abdomen for any palpable masses, palpable bladder, kidney or loin tenderness. And then depending on what my history has elicited, I would decide whether it's appropriate to undertake a pelvic examination at that time as well.
What is the importance of family history in these situations?
So we at the moment, what we have is an ultrasound which has suggested urinary tract calculi, and in some cases there may be a familial or genetic predisposition to forming renal stones, for example, hyperparathyroidism or other metabolic abnormalities.
Okay, so I'm just going to share my picture so that are you able to see this picture?
Yes, I can see that, yeah.
So this is the scout picture of the CT scan.
Okay. So this is a scout image of in a coronal plane of a CT, non-contrast CT KUB, demonstrating a large radio-opaque calcification in the region of the left pelvic ileocecal system, which is highly suggestive of a Staghorn calculus.
Yeah, I need to mention that pictures were taken from the website Radiopedia, which is a wonderful resource for anyone going through any radiological images, not only urology, even general surgery and other specialties. Any other finding in this scout picture?
There appear to be some calcifications or clips in the pelvis, and I think the patient's catheterized.
Yeah, it could be a contraceptive device.
Oh, right, okay.
Okay, and there is a possible small shadow on the right side which you need to mention.
Sorry.
That could not be a significant one, but you need to mention it for completion. Okay, so this is the axial non-contrast picture. Let's go from the top.
Okay, so this is an axial film, an axial plane of a non-contrast CT, demonstrating what appears to be a Staghorn calculus encompassing the left pelvic ileocecal system, with an additional calcification in the right renal pelvis, suggestive of a right renal stone. There doesn't appear to be any distal.
Yeah, so there is no stones in the distal ureter, and as we expected, that's the
there's a Mirena coil.
Mirena coil or whatever the contraceptive device intrauterine. Okay,
Yeah.
we have the other pictures if you want. So
Okay.
we're going from front to back.
Yeah, so this is a coronal slice of a CTKB showing a complete Staghorn in the left pelvic calyceal system and a right-sided renal stone.
Okay, so how are you going to treat her?
Okay, so we've undertaken a history and examination. I'd like to assess the patient's urinalysis, check their urinary pH. I'd like to establish whether they've got a history of urinary tract infection. And I'd also like to undertake a full set of bloods in the clinic, checking the patient's renal function. From the imaging, also I'd like to comment that the right kidney does appear to be a normal functioning kidney with normal parenchymal thickness and no distal obstruction, and there's no anatomical abnormality based on that CT. So I will begin by explaining to the patient that she has a large stone in the left kidney, which may have resulted from urinary tract infections over time. And I'd explained that this is known as a Staghorn calculus, and our treatment, our guidelines would suggest that these stones should be treated and not managed conservatively. We know that from historical cohort studies, which have demonstrated that Staghorn calculi which are managed conservatively have high proportion of complications and are predictive of mortality. So my advice to the patient would be that the next step is to undergo a nuclear medicine scan known as a DMSA to evaluate the function of that kidney, ensure that it is a functioning kidney, and also to undergo a CT urogram to evaluate the anatomy in more detail, as this will allow us to guide our next phase of treatment. And that the treatment modality would be a percutaneous nephrolithotomy, or Pcnl, and I would augment this discussion by using a BAUS patient information leaflet to fully inform the patient of all the risks and benefits of this operation.
Okay, you are doing a DMSA scan, accepted, but do you expect this patient kidney to be of low function, any chance?
No, it does appear to be a normal functioning kidney from the CT scan, but I guess we don't know how long it's been obstructed, how long the stone's been there for.
Okay, so
it wouldn't be absolutely necessary to get this DMSA.
Yeah, it's nothing wrong in getting it, but you can mention it like it will serve as a baseline function so that in the post-op, it will help you to fall apart in case if the kidney function deteriorates, etc. Okay, so patient is for PCNL. How are you going to arrange the procedure?
Okay, so depending on my department's expertise, the procedure would be undertaken in either a prone or supine position. So as discussed preoperatively, as part of the planning process, the patient would have a DMSA and CT urogram undertaken. They'd also be assessed in the pre-assessment clinic to see how fit they are for treatment. And on the day of procedure, I would re-explain and reiterate our discussion from the clinic using the BAUS patient information leaflet. So with antibiotic prophylaxis, which in our practice would be gentamicin, if we're undertaking a supine, say we're undertaking a supine PCNL, then initially a cystoscopy and left retrograde study would be undertaken with the patient in the lithotomy position. This would allow a ureteric catheter to be passed to the left collecting system, which would then be left in place. And then with either ultrasound or fluoroscopic guidance and assistance of interventional radiology, access to ideally the upper calyx would be achieved through percutaneous puncture and serial dilatation, and then using either a standard approach, so a standard a caliber nephroscope, 24 to 30 French, or a mini PCNL, 14 to 20, depending on local availability. PCNL would be undertaken with fragmentation and removal of the fragments. Okay,
how will you select between supine and prone PCNL?
So there's no absolute benefit of one over the other. So often this will depend on local expertise and availability. Now, the advantages of a supine approach are that it minimizes the cardiorespiratory complications that are associated with prone PCNL. It also allows simultaneous access from the retrograde approach and the antegrade approach. And it doesn't require, repositioning the patient during the operation. The advantage of the prone approach is that it may allow a easier access to the kidney with a wider field of access, but it does come with anaesthetic complications.
What anaesthetic complications?
So these are mainly related to reduced functional respiratory capacity due to the patient being in the prone position, which results in reduced venous return.
Your audio is sometime breaking. Just keep an eye on
Okay.
your mic.
Yeah, I'll just.
Prone position doesn't necessarily make the respiratory capacity less, because you may aware of, even during the COVID, people tend to do prone ventilation to recruit the upper lobes. But the main challenge is for the anesthetist, because the reachability or accessibility of the endotracheal tube will be slightly difficult, and monitoring patients with the cardiac leads will be slightly challenging in a prone position. And in case if there is a endotracheal tube displacement, it will be a challenging one for the anesthetist to do when the patient is prone, which may require quite rapid desaturation and rapid requirement to change to a supine position. Other than that, in a fairly fit patient, a prone Pcnl has equal possibilities and advantages. And the other thing what you can mention is the anteriorly placed stones. If the stone is quite anteriorly placed, sometimes the prone Pcnl will result in kind of a double puncture. You need to puncture the posterior calyx and then use that calyx to reach the anterior calyx. Those are all the small tricks we can discuss. What type of Pcnl you are going to do for this patient? What kind of sheath?
So of a stone of this size, the two options are either a standard size, so 24 to 30 French sheath, or in some cases, although it may not be as successful, a mini approach with a 14 to 20 French.
Okay, so what is the main advantage of this new concept of mini Pcnl?
The main advantage is lower morbidity, so a smaller puncture, smaller sheath size, which may allow the patient to be left without a nephrostomy in either a semi-tubeless or a tubeless approach.
Okay, what is your choice for this particular patient?
I would advocate a standard Pcnl given the stone burden.
Okay, so how will you access the kidney? What is your approach to reach the pelvic calyx system?
Okay, so ideally an upper pole puncture through an upper pole calyx would be made, which would allow good access to the renal pelvis.
Why upper pole puncture?
I think given where the stone is, it would allow easier manipulation of the nephroscope within the collecting system.
Yeah, from the upper pole, the chances of reaching the whole pelvis and PUJ and sometimes even the lower calyx is easily possible. And also, patient being a female, you can take the scope as parallel to the thoracic cavity. While if you do a lower pole puncture, sometimes you may find it quite difficult to reach the upper pole calyx, and patient's gluteus will be quite inhibitory, especially in women. Both the approaches, you will have difficulty in reaching the middle calyx, but with baskets, with availability of the flexible nephroscope, you can cover the procedure with one puncture, and if necessary, you can go for the second puncture. What is your energy source in this standard Pcnl?
So you can use various different energy sources. So you can use a ultrasonic intracorporeal lithotripter. You can use holmium laser. I have experience of using both devices, but you can use most commonly would use an ultrasonic based lithotripter device.
Okay, how it works?
If you use the Trilogy device, for example, it uses a combination of ultrasonic and like a ballistic method, which uses high frequency ultrasound which is a vibrating element at the tip of the nephroscope, which drills and fragments the stone.
Okay, so you are doing an upper pole puncture, and what is your view on getting a radiologist to help in the puncture, or do you want to do yourself?
Yeah, so the puncture should be undertaken with assistance of interventional radiology. So I don't have personal experience in access, and this would be undertaken primarily by interventional radiology using either ultrasound or fluoroscopic guidance.
Okay, so you are placing the, say, access sheet measuring 26 French in the upper pole, and you are using the triology for clearing the stone, and you manage to clear most of the stone except for maybe a fragment measuring 9 millimeter in the mid pole, which is not reachable. What is your choice next?
Okay, so if this has been a supine Pcnl, then there's an option to simultaneously access the kidney via retrograde approach and fragment the residual fragment with laser. Second option would be to plan a second stage procedure. So if the middle-calyceal stone is not accessible from the percutaneous approach, then to plan a ureteroscopy. So either at the same sitting or a delayed second stage procedure, depending how the Pcnl has gone.
The other option you can use is you can just use the puncture needle to puncture the middle calyx and use it to push the middle calyx stone into the pelvis or slightly immobilize it so that you can still reach it through your upper calyceal puncture. You may end up doing an extra puncture but not really dilatation and tract, etc. Okay, the procedure is over now. What is your exit strategy?
Okay, so depending how the procedure has been, whether there's any residual fragments or not, or whether there's a plan for a second procedure, the options would either be to leave a nephrostomy in situ, which can then be clamped day one and removed if the patient is draining satisfactorily and has no significant pain. Second option would be to leave a ureteric stent in situ and take the nephrostomy out. And the third option would be to leave the patient without a stent or a nephrostomy. These factors will depend on whether the procedure has been uncomplicated, whether there's been complete stone clearance, whether there's any suspected infective element to the stone, whether there's any extravasation of urine. So those are the options post-operatively. These patients would obviously be admitted to the urology ward overnight, monitored closely, and depending how they are the following day, they may be able to be discharged. The stone fragments will have been sent for analysis, and the patient will be followed up depending on to undergo a comprehensive metabolic stone analysis.
Can you explain what you will do in the metabolic stone analysis?
Okay, so the first step would be for the patient's serum markers to be evaluated. So this would include a serum calcium and in some cases a serum urate and phosphate. I would also evaluate the urine and undertake a 24-hour urine collect, so two 24-hour urine collections. So I'd advise the patient that this is required to evaluate levels of salt and other factors within the blood, within the urine, which may put the patient at risk of developing further stones in the future. I'd advise the patient to choose 2 days in the week, which are most convenient for them. They would have 2 containers, one containing hydrochloric acid, one containing one plain container, to wake up, void the first void and discard it, and then to collect every urine specimen that they void for the next 24 hours, and then to repeat that ideally the following day, and to deliver both containers to a GP practice or the hospital. This would give us an idea of the 24-hour urine volume, pH, and various electrolytes and other components such as citrate within the urine. We'd also evaluate the metabolic analysis of the retrieved fragments from the Pcnl, and this will guide whether the patient is suitable for any preventative strategies.
Okay, why do you want to have 2 collection bottles? What is the role for the hydrochloric acid?
So the hydrochloric acid prevents spontaneous precipitation of crystal components. So with within the acidic bottle, we would collect calcium phosphate and citrate, calcium phosphate and citrate, and magnesium. And in the plain bottle, we collect, we would evaluate urine pH, the volume, urate, and uric acid and electrolytes, so sodium and potassium.
Okay, this patient's stone analysis reported as Struvite stones. So, what advice you'll give her?
So Struvite stones are indicative of chronic infection. So they form in alkaline urine, normally in association with chronic gram-negative urinary tract infection, for example, Proteus or Klebsiella or Enterobacter. So fundamentally, the preventative advice to all patients should be similar. So maintain a high fluid intake, 2.5 to 3 liters of fluid per day dispersed throughout the day, to maintain a dilute urine output. Maintain a normal calcium intake, low salt and low animal protein. And then specifically with this patient, if she has a history of urinary tract infection, we must try to reduce the risk of that as much as possible by providing general preventative measures to reduce risk of urine infection, and with satisfactory treatment and complete treatment of recurrent infections. Okay,
if the stone analysis is calcium oxalate monohydrate, what advice you will give her?
So the basic advice would be similar, but I would also check the patient's serum calcium, and if they are hypercalcemic, then this would be indicative of primary hyperparathyroidism, which would require referral to endocrinology. If they have if they are hypercalciuric, then there may be an option to treat with a thiazide diuretic if this is thought to be renal leak hypercalciuria.
Okay, that's good. And I don't think they will go any more depth compared to what we have discussed now. Before we conclude, do you have any questions to ask?
No, I think it's okay. Yeah, just a few things to brush up on for that one, I think.
Yeah, just be very confident on this metabolic evaluation. You are doing fine, because that question will be usually coming in the fag end of the scenario, and that answer is the only thing stands between you and mark 8 or 7. So, but you are doing good. Nothing for me to add. Okay.
Great.